Um, uh, uh, so we're going to do the last of the 3 of electrophysiology talks we had today. And today we're going to focus on electrocochleography and its applications in neurotology. So my kind of agenda is to review the major components of the ECOG response, review the interpretation of the ECOG response, discuss its application in both Meniere's disease and superior semicircular canal dehiscence, and then maybe review some of the theories of why we see ECOG changes in these disorders. So what is electrocochleography? Well, it's basically a recording of the electrical potentials from the cochlea itself, as well as a major response from the distal component of the 8th nerve. And so you tend to think of 3 waveforms in an electrocochleography recording. One is the cochlear microphonic, which is a response that is generated by your outer hair cells. And basically that response is going to mimic the waveform of the acoustic stimulus. And then when you change your stimulus from, say, a single polarity rarefaction to condensation, you'll see changes in the cochlear microphonics, which is here on the screen. We're really not going to talk more about the cochlear microphonic. That, as you know, that may have been a more relevant discussion in the auditory neuropathy talk that Dr. Fruta gave a couple weeks or couple months ago. The 2 major components we typically are looking at interpreting for the responses we're going to look at today are going to be the summating potential, which is a response generating from intracellular potentials, predominantly the inner hair cells. It's a DC potential, so that it's not going to change its polarity when you change the polarity of your stimulus. And then you also often see that it says it follows the stimulus envelope of the cochlear microphonic. And remember when I was first reading that, that seemed like a really confusing response. But basically, it just means that the summating potential is going to have about the same amplitude as the peaks of your cochlear microphonic. It's just not going to follow all the contours of the individual waves. And then the last response is the cranial nerve 8 compound action potential, which is summoned activity from synchronously firing cochlear nerve fibers. That is synonymous with the wave 1 of the ABR response. And so typically this ECOG response is at the bottom here is what we're going to be looking at in most of the other pictures we see today. And this is going to be generated by using an alternating response that alternates between rarefaction and condensation stimuli. How do you record this? Well, you record this by getting as close to getting an electrode as close to the cochlea as possible. You can do it with metal wrapped insert headphones, which they sometimes will call tiptrodes, but we find those responses typically not reliable enough to interpret it on a regular basis. So you're generally going to want to use some sort of tympanic membrane electrode. There's a couple different ones that are commercially available. This is the hydrogel. This is an electrode that's coated in a little blue gel that's placed down on the tympanic membrane. The other electrode that we use is called the Lillywick. This is an electrode that's got a little cotton ball, which you dip in a little either saline or a little conducting gel and place it directly on the tympanic membrane. And I believe I have a little video here demonstrating this getting inserted under the microscope. So typically when you do this, you're going to use a nasal speculum rather than an ear speculum, because you can remove that speculum around the electrode without dislodging it. So you get a nice clean view of the eardrum. With someone with a smaller ear canal, it can sometimes be hard to see past your electrode when going in, but you're going to basically work it past the canal, set it down on the eardrum, apply a little pressure to the tube to keep it on there while you remove your speculum. Then you'll squish up an insert earphone, put it down in the canal, deliver your sound stimulus, and then proceed to do your testing. You can also do this with a transtympanic electrode, which actually gives you great, beautiful, very large amplitude responses, though it's, you know, a more painful procedure. But you can do this by placing a recording electrode through the tympanic membrane onto the promontory. Obviously, if you're doing this in a awake patient, you got to put some numbing on the earphone, on the eardrum itself. Typically, we don't do this in the clinic. We just use the TM electrodes, but this is a completely viable way to record these responses too. And so we typically are going to look at the ratio between the SP and the AP responses. And so I'm just going to quickly go over how you measure that here. So here we have your summating potential and your action potential responses. The first thing that you want to do is pick a baseline response on your waveform. This needs to be an early response in a relatively flat area of the electrode. You might be tempted to place your baseline here, but that negative kind of dip in the waveform is actually a part of the response. And so you don't want to put that there, because that can, we've learned, throw off your SP and AP calculations a little bit. So you don't want to put it there. You want to put it at an earlier waveform such as there. You mark that as your baseline, and then that is going to be the point from which you measure your summating potential amplitude and your action potential amplitude. So in this case, you would measure from that line to the summating potential, which happens to be 0.3 microvolts. Then you're going to measure from that line to the AP, which there is 1.2 microvolts, and then you do some math, and that turns out to be you know, about 0.25 ratio. And so I'm going to show a little video. This is just a little video of a live recording on a clinic patient. And so why do we look at the ratio between the SP and the AP? Well, we know we can find that the actual the absolute amplitudes of both of these waveforms can be quite variable, and they can be variable between patient, between ears, and they're just too variable to use the absolute things. But you do notice that, and you can hear this patient fell asleep and is snoring in the background. I don't know if you can hear my audio from the recording, but so as you record that, we find that it's much more consistent if you compare the relative amplitudes of the two rather than looking at absolute amplitude criteria. And I will get this to stop playing so I can move on. And so the first disorder that we're going to look at this is in Meniere's disease. So you know, this is not a whole talk on Meniere's disease, but this was the disorder that was diagnosed by Dr. Mannarelli, a French physician, many years ago, and it's a rare disorder that affects the inner ear. It can cause vertigo, tinnitus, hearing loss, feelings of pressure or fullness in the ear. It's also known as idiopathic endolymphatic hydrops because it's thought to be related to increased pressures in the scala of the inner ear. And so why might we use electrocochleography in hydrops? Well, it has several applications why someone might want to add this to the test battery. You know, I think in many cases you can diagnose Meniere's without needing to necessarily perform an ECOG on all of these patients, but there are certain situations where having this data can be a little helpful, and so you can use it to rule in or out hydrops when you might be considering a Meniere's disease versus some other disease that can cause somewhat similar symptoms, such as migraines, vestibular migraines. It can help determine the laterality of hydrops when other vestibular function tests are equivocal to determine if you're dealing with a left or right disease. You can use it to rule out bilateral disease prior to performing an ablative procedure. If that ablative procedure might have long-term complications for the patient if it turns out their other ear has Meniere's disease as well. And you can also use it in research to kind of confirm the effects of treatment regimens, or even to determine if your other your medical management is being effective in the patient, in a Meniere's patient. So we know from studies here, this is a recent study published, that increasing pressure within the cochlea and in the various scales of cochleas is going to have effects on your electrophysiological reportings, where you can see increases in the SP amplitude, increases in the cochlear microphone and AP thresholds. In more advanced cases, you start to see reductions in the AP amplitude. And then the major thing is, if you're looking at a click-induced stimulus, you're going to see increases in the SP to AP amplitude ratio. So recording of these responses go way back to the 1950s. This is Dr. Hallowell Davis, kind of one of the founders of modern electrophysiology. And he was doing studies in guinea pigs showing that, he was inserting pipettes into the scala tympani of chinchillas and recording the electrocochleography changes as you're applying different pressures to the scala tympani. So we've known that that pressure changes in the inner ear affect the ECOG response, for many, many years now. This is another study, a little more recent, that looked at instead of this was changing the endolymph pressure in the scala media rather than the scala tympani, and it's showing that there's a mean amplitude increases somewhere between 1 microvolt to 3.3 microvolts. As I said before, the absolute amplitude responses can be quite variable, and then again that there's mean SP/AP increases go up from 0.08 to up to a ratio of 0.31. This study also showed that this happens not only to click stimuli, which is often been used, but to tone burst across the spectrum of the area to show that this isn't isolated to necessarily one region of the cochlea. So what is a normal ratio when you're looking in a Meniere's patient? Well, typically we want to see an SP ratio of 0.4 or less. So what I have here is a right ear response from a patient with an abnormal ratio, where you see we have our baseline. Here's your summating potential, and there's your amplitude. And then so we did some measurements and calculations and show that ratio is 0.64. Also, if you just kind of look at the, eyeballing it, you can kind of see, yes, this response here is, well over 40% of the amplitude of this, right? It's, so you could tell that's abnormal just by glancing at it without even measuring it. So that's how you interpret it. You're going to be looking for a ratio of 0.4 or less. So I just thought I would kind of give us one case study of a use of electrocochleography in a Meniere's patient. So here we've got a patient with a history concerning of Meniere's disease. She also has migraine-induced vestibular symptoms. She does have a history. So, you see this is a patient that has multiple possible potential causes for her vertigo, dizziness, and some of her auditory symptoms too. But she has a constant right tinnitus. She's got a history of bilateral rising sensory neural hearing loss. I don't have bone conduction on these waveforms to simplify it, but they're both sensory neural. Her right ear is worse than her left. It tends to fluctuate. It has poor fluctuating word recognition score. Word recognition is always consistently poorer than the left side. And the right side tends to fluctuate more than the left does. So in this patient, the suspicion was that this was a right Meniere's disease, but because of all of her complicated symptoms, ECOG was kind of ordered to confirm that it was a right Meniere's, or the main thing was wanting to rule out bilateral Meniere's. And so here is kind of these ECOG responses, and here I might ask the audience a question. So I don't have any numbers on the screen yet. The red tracing is for the right ear, the blue tracing is for the left. And just by kind of eyeballing it, does anybody have any impressions about these waveforms?
Well, I'm going to answer that. The low one, the red one, that's the right ear, correct?
Yes.
Yes. So then that ratio looks like it's definitely greater than 0.4.
Yeah.
And definitely, and the left one looks closer to normal. One would expect, yeah. So I think that's still right, Phineas.
Yep. So here we go. Yep. So that's exactly right. So there's our SP ratio, which if you when you look at the numbers was 0.23 and the right SPAP ratio was 0.64. So yeah, there we go. So what implications might this data have in planning this patient's care for the future?
Okay, Peter's quite keen to answer. Yeah.
I know that. So it means that if there's any intervention, it should be for the right thing.
Yeah, and what interventions? Yeah, what interventions do you have at the statement with right simultaneous?
I think we could try medical therapy, intratympanic symptomizing teaching.
Anything else? Okay, I'm not sure. Maybe you can hear what Gift is saying. He just said medical interventions, yeah. And what other interventions besides you said medical? What other interventions would we try?
Okay.
No, we really saw that lifestyle.
Reduce salt intake, and
yeah.
Yeah, I think that's all true. And I also just think there's an important counseling patient. You've got a patient with bilateral progressive hearing loss. I think you can say, yes, we have more evidence that we don't have any evidence that you're getting Meniere's in your left disease. It's not likely you're gonna, if we do some sort of definitive treatment on the right ear, we kind of have a stronger feeling that it'll be successful, that they won't start having residual symptoms generated for the left ear. Or if you have a patient concerned they're gonna eventually go deaf or develop more significant hearing loss, we say, no, we don't think the same disease process is causing your left ear hearing loss that is your right. So I think it's a useful counseling tool.
Question. Is it predictive that they won't develop it in the other ear if you have a normal SPAP ratio, or is it more of a point in time to say right now it looks like your left ear is not affected, but do we know if there's any predictive value going forward in terms of looking at an ECOG?
Yeah, no, I don't think it. No, I think that's an important point, that it's probably not. In fact, ECOG responses can change day to day, even depending on how symptomatic a patient is. So, yeah, I think it's not the definitive thing, because it could be, sometimes you want to try to test these patients why they're symptomatic, or if you see an ear that's fluctuating, if you test it on a day that it's down, then you might be more likely to see a positive response. And I think that's part of the reason why it's not necessarily always kind of a standard universal test, in ECOG, and that you have to use it's just another data point to use.
One other question, do you ever use glycerol dehydration? Very early in my practice, one of my partners liked that a lot. If they had a SPAP ratio that was off, he'd give them glycerol that would dehydrate, I guess it was an osmotic dehydration method, and he'd see a change in the SPAP ratio. Do you ever use that at all, or is that sort of passe?
We don't. Yeah. In fact, so in terms of like what from our otolaryngologists, I actually had to go back years and years to actually find a case study where they asked us to do an ECOG in a Meniere's patient. It seems that the one physician that ordered it a little more often is no longer with us, so it's used kind of, and Greg, I suppose you can comment on this too. It's used relatively sparingly in the Meniere's population. I think there's certain cases where adding a little more information for additional clarification is helpful.
Yeah, that's right, Greg. Yeah, Brad, we typically use it more for SSCD cases. Most of, as we know, most of Meniere's it's a clinical diagnosis. So really it can take quite a while to make that diagnosis. Particularly, I think the big take home here too is if you have layered vestibular migraine on top of suspected Meniere's, that's the great mimicker of Meniere's is vestibular migraine, because those folks can present very similarly to a classic Meniere's patient. So they can be tricky to diagnose. So I think it takes time. They have to do some home sort of documentation with symptoms, and it can take weeks or months to do that. I think the key here is to not do anything irreversible to these patients. You certainly don't want to put them in harm's way or do something that could damage the inner ear, particularly if it's a migraine issue. But yeah, Greg, we just don't do that very often with anymore. I think it's all about clinical.
Yeah, and that's why I think this was the one patient I found where it's just, I think, a patient where another data point would be useful because they're so complicated, right?
Right, exactly. It takes time to figure these folks out sometimes.
And the physiology is really cool too.
Yeah. Okay, so now we'll move on to, well, I guess were there any more questions on the Meniere's component?
One question on because mainly because I've got a patient who's fairly similar. We don't have our audiologist can't do electrocochleography at all. And I think she's one of those patients who's got Meniere's and then a bit of vestibular migraine. Her audio looks fairly similar. So my question is to Professor and Prof. Welling. Would you be concerned? I can't identify a side. It's very difficult to know because both the audio looks very similar to the patient that you've just shown. But is there a concern with using gentamicin? Obviously, because you're not sure that patient one, you can't identify which side is kind of the one that's the culprit. And the other side, even if we had electrocochleography, is there concern that they, with gentamicin ablation, that they won't be able to compensate? I mean, is that an issue, do you think? Or am I being a bit silly? That there won't be that sort of central compensation if the other side is also developing that hearing loss.
Yeah, no, I think as Dr. Basura alluded, you certainly want to be as conservative and not destroy any function as you go along. And so gentamicin is last case scenario. I mean, it's one of the last treatments we considered. But if I understood the question, I didn't hear the first part completely. I would say we would certainly try to do more conservative things when we think there's a chance that the other ear may be involved. Even in this case where the SpAP ratio is normal in the left ear, we try to do more conservative things like dexamethasone injection, or even consider an endolymphatic shunt in the ear that seems to be active in its Meniere's, given that the left ear has a kind of fluctuating pattern as well. And so therefore being conservative is always the best first choice, I think.
Mm-hmm. Yeah, Tashim, I can't remember when we did our vestibular lectures. Are you guys able to do water or air calorics?
Yeah, we can do those, but we can do G's, we can do calorics, but they don't have that. They're just not sure how to do electrocochleography. They've never done it. I asked once and it was just like, we don't know how to do it. We've never done it.
Yeah, that can be helpful sometimes to look at if they have a predisposing peripheral vestibular weakness that could, impact your clinical decision making about the contralateral ear. So you don't convert them to a bilateral vestibulopathy patient for sure. I really have a lot of my patients do a lot of home journaling. I have them keep a quote unquote dizzy journal because, a lot of these things will be patterned. If they really have Meniere's, that'll really disclose itself, fullness in the ear, roaring, tinnitus. They'll really know that typically on a unilateral. I don't see too many bilateral Meniere's patients. So whenever I see that, it makes me wonder about migraine, but I still don't rule that out. But a lot of those folks, before I use gent, there's been a lot of run up to that before we do that. The symptoms are really reliable in that patient, and then you can track them with audios. You might see that ipsilateral ear that they note subjectively. We can track low to mid frequency fluctuating hearing loss typically on an audiogram. So those are, I just try to get as much data as I can before I do something like a chemical ablation. to make sure. And I will interrogate the other ear before I do that as well, because I don't want to do damage that leaves them in a bilateral situation. Yeah. They're tricky patients. They're challenging to care for. They are. It takes a lot of time, and patients, they're desperate sometimes, like, oh, I got to get something done. I'm suffering here, but you don't want to do something too quick and then make them worse off. Yeah.
Yeah.
Okay, great. Thanks. That's awesome discussion. So we're going to now talk about ECOG's application in superior semicircular canal dehiscence. So you really can't talk about disorder without giving credit to Dr. Miner, who kind of over the years kind of defined this anomaly, and also was fundamental in looking at vestibular evoked myogenic potentials, which I'm not going to talk about today, but that was kind of the original test that you can use to kind of confirm superior semicircular canal dehiscence. And so what is this? It's a newer, I don't know if this is an older slide. I don't know if I can call it newer anymore. It's not newer anymore, but it's a relatively newer clinical entity encountered by audiologists and otologists. It's when a portion of the bony labyrinth, most commonly over the semicircular canal, though it really can happen in other canals too, but by far most common in superior canal, where that portion of the bony labyrinth is dehiscent or missing, and it causes a number of signs and symptoms in these patients, including Tullio phenomenon, which is sound-induced eye movements. They're going to have an unstable horizon, conductive hearing loss in the presence of normal emittance in otoscopy, with typically supernormal bone conduction. They're going to have nystagmus with pressure to the ear or a fistula sign. They're going to have abnormal posturography, and often these patients will kind of just have general vague kind of gait complaints. Some of the yeah, go ahead. Oh, okay. Some of the auditory manifestations include hyperacusis to bone conductant sounds, autonophy. They'll get pulsatile tinnitus, oral pressure. They're going to hear their own footsteps exceptionally loud. They can complain of hearing their eyes move. And again, they're going to have airborne gaps in audiometry. They're going to have sound and pressure evoked vestibular symptoms and lower VEMP thresholds. And we think some of this has to do with this opening in the system. I think you always kind of have to remember that your vestibule and your canals and your scala of your cochlea are all kind of all interconnected. And some of this energy is going to be shunted away up through the dehiscence, reducing the overall energy in the cochlea, thus creating kind of a hydraulic-based conductive inefficiency in the system, resulting in this conductive hearing loss. And then it's kind of was observation, some folks here at the University of Michigan, that these SSCD patients also tend to have elevated ECOG. I think a lot of credit to this goes to Dr. Paul Kalani, one of my mentors, and then a couple of his neurotology colleagues, Dr. Arts and Dr. Adams, kind of put all this kind of ECOG to data and did kind of the first publication on this topic. And ECOG in SSCD patients has been an increasingly relevant tool in our practice at Michigan Medicine in the United States. And I think some of that has to do with, the other kind of electrophysiology test you can do is the vestibular evoked myogenic potential, but insurance coverage in the United States for the VEMP is relatively poor, where coverage for an ECOG test is almost universally covered. And so just by, kind of almost by the insurance companies have made this the default, test, electrophysiological test, in addition to the CT scan for these disorders. Like I said, when I was looking for case studies for this talk, I found, hundreds of ECOG SSCD examples, and I had to go back years to find that patient where we did it for a Meniere's patient. So we'll do a quick study, a case study for an SSCD patient. This was a 27-year-old pharmacist with a history of, did this one interesting because this patient also has a history of migraines, ovarian cancer, which is in resistant, and a 1-year history of dizziness described as room shifting. Symptoms are accompanied by nausea. They were not typically associated with her headaches or her migraine aura. Her symptoms were worse by straining when she was doing like a Valsalva maneuver or blowing her nose. She initially had vestibular, our kind of what we call our conventional vestibular battery, symmetrical caloric responses, no spontaneous positional or post-head shaking nystagmus. Rotary chair testing was normal. Oculomotor and posturography testing were normal. And they also obtained a audiogram, CT, VEMP, and ECOG. Just in the interest of time, I'm going to skip the VEMP testing. But here's her audiograms, which showed mild low-frequency conductive hearing loss in the right ear with supranormal bone conduction thresholds at 250, 500, and 1,000 hertz. She has excellent word recognition bilaterally. Normal tympanograms, intact acoustic reflexes, negative reflex decay, so her remittance study was completely normal. And I guess my next question for the audience is what's the significance of the intact pro-bright acoustic reflex? Like she's got a normal reflex in this ear.
Just another way of asking that is Greg is saying if she had absent acoustic reflexes with that low kind of lowest conductive hearing loss, would that tip you off to a different diagnosis, or what would that make you think about?
Yeah.
Alternatively, what would that make you think about?
If you worried about otosclerosis, which is
Right, exactly. Otosclerosis, right? Because then you're going to miss right. If the stapes is fixed, you're not going to fire the acoustic reflex. But it can present with the pure tones with bone and air conduction this way. So the big difference. So when you see that without the reflexes, you're kind of left to think it could be one of those two. If it's not like a perforation of the drum or part of maybe the ear bone chain is compromised, for example. So that's the big utility there is in SSCD, you should have acoustic reflexes, right? So that's the big trip there. So if you see that and your audiologist hasn't gotten the acoustic response or the reflexes, you want to make sure you get that.
Yep, that's exactly my point. Is if you get these patients with normal tympanograms and conductive hearing loss, you always want to try to get acoustic reflexes because that alone often can differentiate between a otosclerosis or a superior semicircular canal dehiscence. I never miss up a point to mention that. And so this was her CT scan, which showed a clear semicircular canal dehiscence on the right ear and a very near dehiscence. If you look closely, there's a little bone line right there over the left. So she's nearly got bilateral disease, but a kind of a clear, more significant dehiscence on the right, which fits her other testing. And then here was her electrocochleography again. Again, left ear, maybe getting close to abnormal, but we're still well within the normal range, right? It's not something small like 0.1 or 0.2, but it's within the normal range. And so you had a normal SPAP on the left, and the right ear, again, just kind of looking at the eyeball test, it's about at least 50% of the ratio between the SP and the AP. So you've got an abnormal SPAP on the ratio. And the resolution of this patient was, she was mostly just happy to have her symptoms explained, right? She kind of felt like she was going a little crazy with all these unusual symptoms. She didn't seek any kind of treatment for it. but she just was very happy to know what it was and was able to happily go on with her rest of her life, and comes in every so often to have her hearing and monitored and things like that. But just telling these patients sometimes what's going on is all they need. Other patients will go on for some treatment. So I just wanted to talk, let me see how much time we have left here. I'll get plenty of time. I wanted to talk a little bit about why we think with these changes. I find this a little bit interesting. So this study, Butler and Honrubia, goes way back to the 60s, and they kind of mapped out changes to hydrostatic pressure in the cochlea, and this was an animal study, and they again kind of graphed out as you applied increased pressure to the scala tympani, you saw generally decreases in your SP, and as you applied pressure to the scala vestibuli, we see the AP dropping and the SP increasing, which, here's a situation where we would see an increased SP-AP ratio. And so this is a little bit interesting. So when they applied pressure to the scala tympani, thus deflecting the scala media up kind of towards the vestibule, they saw decreases in the SP and the AP likewise. And then when they applied pressure to the scala vestibuli, deflecting the scala media away from the vestibule, is when we see the SP and AP increasing. So when you look at this, it kind of at first glance, you're like, oh, well, I've got this dehiscence in the superior canal that would kind of decrease the pressure up here, and you would think you would get your scala media kind of deflecting up towards the vestibule. But what we see, according to the SP-AP ratio, is kind of the exact opposite, where we're getting elevated SP-AP. So what's happening somehow in this disorder is that we're getting some sort of, likely the opposite of what might the intuitive response is. We're probably somehow getting some basilar membrane, scala media deflection kind of away from the dehiscence and these things. And so a relatively recent study came out, and these were engineers that did this. But they did some 3D modeling of kind of resonances of waves in the inner ear. And what their modeling showed up, as I can play this video, is that, what actually happens in the superior canal is it kind of creates a point of greater deflection, and that kind of movement is creating various standing and traveling waves that are kind of reverberating back through the canal. And they kind of hypothesize that these ricocheting waves are kind of both creating a pumping effect in the endolymph, which is kind of setting the endolymph in motion, kind of potentially deflecting the outer hair cells and inner hair cells, so they might be more prone to fire, and felt that the standing waves could be kind of creating deflections that are helping open these ion channels. So I kind of base point that side is, these kind of always what your first kind of intuitive glance of what may be happening isn't always there. These fluid motions in the inner ear were obviously designed to be in a fixed closed system, and when you create an opening, it creates an avenue for all these abnormal kind of resonant waves diffracting all around the inner ear, creating all these unusual kind of patterns, which is probably why these patients get all this array of unusual symptoms. All right, I'm just going to kind of close up by going over some intraoperative applications of ECOG in SSCD patients. So we tend to, you're able to kind of even monitor for the patients that do go on to have surgical correction of their SSCD. You can actually monitor the changes to the ECOG in real time. So I just have some clips of SP-AP ratio changes throughout a plugging procedure. I believe this is a middle fossa procedure. So this first video is just kind of our baseline ECOG waveform, which you can see is the bottom tracing here. This upper one's just your conventional ABR. This is facial nerve monitoring up top. But you can see here, this patient had a very elevated SP-AP ratio. I will point out that this was me doing this. I did have a little no-no here. I do have my baseline and the wrong response. Don't, do as I say, not as I do. But regardless of that, you can tell this is a very, very elevated SP-AP ratio at baseline. And then the next video is going to be when the dehiscence was exposed. And so I've shrunken the scale down here because we saw such a large amplitude change between the SP and AP ratio. So here, when you look at this small tracing now is the baseline, and this is your elevated SP-AP ratio. And so you can see, even as you can, this kind of I put in here to kind of go to my point that you can't look at the absolute values because they can fluctuate even within the same patient within the case, but your ratio tends to stay consistent. This is a great video because we actually were able to catch the, as you expose the dehiscence and get kind of the brain off of the canal, this was in a middle fossa, you can actually see your SP dramatically increase sometimes to up to the point where the ratio is greater than 1. And we were actually in this case, actually able to capture the SP, why it was kind of increasing in real time. So this one's a fun video to watch. So if you watch here, and the focus gets a little better, as we're recording, you can just watch the SP here. It's slowly starting to get bigger, 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 to the point where now the SP is actually higher than the AP. And then this was at the conclusion of the plugging, where you see the SP-AP kind of return back down to a normal ratio. So this turned down to a ratio of about 0.2. So those are all recorded in real time. And this was just published by one of our former residents, came out last year, which was kind of a summary of these intraoperative changes. So you've got three columns here. Our surgeons, again, this talk is not on surgical correction of SSCD, but they can do this both through a transmastoid or a middle cranial fossa report. So we've broken this data out by surgery, and you can see this was our preoperative clinic ECOG, showing that these patients on average had elevated SP-AP ratios. This was the ECOG SP-AP ratio at baseline in the OR, which showed it was still abnormal, though it varied a little bit from the clinic testing. And this was, I believe, the intraoperative ECOG post-repair average, showing that, statistically these patients improve down, well below their SP-AP ratio, even on the day of their surgery. And so this is going to be a very quick one, but my last case study here is going to be, another maybe potential application of SP, the ECOG in looking for SP-AP changes. This was actually on a middle cranial fossa. This is some tracings we took from a middle cranial fossa a resection of a vestibular schwannoma in like an 18-year-old patient. And during this case, while the surgeon was blue lining the superior canal, probably created a dehiscence, or probably created a dehiscence in the superior canal, kind of on the approach of this tumor. And so you can see here, this was kind of your baseline response. And then here is when they were blue lining the superior canal and they created the dehiscence, and you got an elevated SP-AP ratio. And then a few minutes later, this is about 3 minutes later, we saw a very significant spike up in the SP-AP ratio. So what the surgeon did was just kind of put some bone wax over the superior canal, and then we just saw it immediately normalize here. And then even this was kind of later in the case, it went, basically back down to a normal level. So something we always kind of keep our eye on when the surgeons are doing middle fossa approaches for things, just as a way to let them know. I mean, a lot of times they'll know themselves, but you can kind of confirm that you haven't created a iatrogenic dehiscence during another case. And just this here, I kind of blew up and overlaid here the baseline SPAP ratio showing when it was elevated. So just in wrap up, I think my approach on the ECOG is that a study that you consider anytime in any disorder that can alter the intra-aortic or intra-labyrinthine pressure, which includes endolymphatic hydrops, or any dehiscence of the bony aortic capsule, commonly in SSCD, in cases concerned about perilymph fistula, or even in other third window disorders such as enlarged vestibular aqueduct. ECOG can be used intraoperatively to monitor the audit system and help improve or maybe predict outcomes in SSCD repair. Super elevation of the ratio intraoperatively can be used to confirm the location of the dehiscence, and ECOG can be used to monitor for iatrogenic SSCD and other surgeries. And I think that is the end of my talk, unless anybody else has any questions.
Oh, that was a fantastic talk. Thank you very much. It really helped to have the case reports as well, just to kind of practically go through how to interpret and how to use it. So thank you very much for that.
Yeah, I guess so. The one thing, I just wanted to point out is you use it in all these different disorders, but it's going to be interpreted the same way. You're looking for the same abnormality in if you're looking for, a bony disorder or, Meniere's disease or whatever, you're looking at the norms are the same, the waveforms are the same, and the way you interpret them are all the same. So it's not like you have to learn different interpretations for its different applications.
Yeah. Yeah, I just wish we had this. We don't, unfortunately, in the States, we don't have it, but something that we do have to know for our exams. But thank you very much for the talk. It was actually a great talk. Thank you. I don't know if Prof. Whalen is still around. Prof. Basura had to leave and Prof. Harris also had to leave. I don't think Prof. Whalen is still on. I don't think so. No, I don't think so. But I don't have any questions. You guys have any questions? No. I don't have any questions. Thank you very much for
No, I appreciate you. Thank you for inviting me. And
yeah, I think we in the meeting. I don't have any other questions, and I think Prof. Whalen is
yep.
Okay.
Yep. All right. Have a good thing and start of your new fellowship and all that. Yep.
Yeah. Thank you very much. Okay. Have a good weekend.
Yep.
Bye.